Right, I think we'll make a start. Thank you for coming back for the final session of the day. We have a relaxed session for you this afternoon. We know that you've taken in a lot of information both this morning and earlier on this afternoon. So this roundtable discussion will be on healthcare models for adolescent HIV healthcare delivery. So I know many of you in the room do work with adolescents directly and might be wondering, well, if I want to set up services for adolescents in my country, in my settings, and I have specific challenges, what kind of things have been done and how could I learn from these things that I could adapt for my own settings? And certainly I spoke to some colleagues from the Philippines that I'm going to be waiting for them to come back, and when they do, they told me some interesting things about what they're doing in their space as well. So hopefully this will be a fruitful discussion for everyone. We have a very experienced distinguished panel of speakers today. I'm going to ask them each to spend 2 or 3 minutes introducing yourself and telling us about how you've been involved in adolescent HIV care delivery. And after everybody's introduced themselves and something about what they do with adolescent care, we're going to open it to the floor, and it's going to be a pretty open and relaxed discussion. So that's how this session will work. Our first speaker is Professor Amanda Castel. Thank you.
Thank you for having me. Sawadee ka. So my name is Amanda Castel. I am a professor at the George Washington University in Washington, D.C., and I'm also a pediatrician and preventive medicine physician. I see patients at our Children's Hospital in Washington, D.C., both exposed infants and perinatally infected and behaviorally infected young people and adolescents. So I come to you from the context of the United States, where about 18% of our new diagnoses are among 13 to 24-year-olds. About 71% of them nationally are able to achieve viral suppression within 6 months, and about 80% of them are receiving care within a 1-year period, and about 69% achieve viral suppression. So in our clinic at Children's, I'm actually a volunteer provider there. Dr. Natella Rachmanina is the lead clinician there. But we see patients up to the age of 24. We have about 175 patients that are in our care. Again, about 80% of them are perinatally infected, and about 80 or 85% of them are Black or African American. And so I think it was Dr. Garges said earlier today something that resonated with me. There was a talk at IAS in Amsterdam, I don't remember what year it was, but David Mailbranch, who's an HIV researcher in the United States, said that the way we deliver care has to be like the way you would go to a restaurant. So if you call a restaurant and you want the restaurant to be nice to you and give you a reservation, and you want to walk into the restaurant and the person at the front desk is greeting you, and you want the food to be good and tasty and healthy, and that's the way that we should be approaching HIV care delivery. And so I always like that example. So in our clinic, we have comprehensive support for our adolescents. We provide services, obviously the medical care, but we provide nutrition support, social work support, psychological support. We also offer transportation to them. So during the COVID-19 pandemic, we were doing both telemedicine and ride share. So we, like the equivalent of Grab, we would have Uber to bring our patients in, and we've been able to continue to offer that service. So that's been very helpful in terms of retention. We also have been able to still offer some limited telehealth about 2 times a week. So for our adolescents that maybe are in university outside of Washington, D.C., they can remote in and have a visit with one of our providers. We've also had some peer support groups. I think most recently we had a cooking class to kind of bring the adolescents together, and they could have peer support and be able to be with other young people who are also living with HIV. In terms of adherence, we've done things like text messaging. We've actually tested some interactive gaming. So where if you were doing well in taking your medications, you might get a badge or something like that to encourage you to engage in care. And then in terms of the transition from adolescent or pediatric care to adult care, we really try to make that a gradual transition. We recognize that we provide a lot of services in the pediatric space that is not provided in the adult space. And so instead of just saying, you've reached the age of 24, you have to go to adult care, we do it in a phased manner so that sometimes it will take 6 months, sometimes it will take a year. We work with the providers who are going to receive our patients so that they understand what their challenges are. And then we help them with that transition. And then lastly, I think I'll just mention that we also try to do regimen simplification. So again, we know that most of our kids are perinatally infected. They've been taking medications for a long time. And so we are talking to them about, are there opportunities to simplify the regimens? Anybody who's eligible for Cabril-Pivarine, we also try to talk to them about that to improve their adherence. So hopefully that gives you a snapshot of what we're doing in one clinic in the entire United States, but we're trying to do our best.
Thank you very much. Our next speaker is Dr. Khin Cho, who is representing UNAIDS. So welcome. You could introduce yourself and tell us about the work you do in the adolescent space. Thank you.
Thank you and good afternoon, everyone. I'm Khin Cho from UNAIDS Regional Support Team based in Bangkok. I was first trained as a medical doctor and then the researcher and then the public health specialist. And in the past 20 years, I've been focusing more on the public health perspective. So the snapshot that I'm going to give is more around the public health advocacy and policy perspectives and approaches. The whole morning I learned a lot in terms of adolescent healthcare, like Professor Thanyawee talked about all these challenges associated with perinatally acquired HIV infections, the vulnerabilities, the drug resistance, all these perspectives. And now I would like to bring another perspective of the newly infected HIV infections among adolescents. Because based on the data that UNAIDS supporting countries to generate through the modeling HIV estimates, what we have seen so far is around 1 in 5, or 20% of new HIV infections in Myanmar, Thailand, Philippines, and Vietnam are adolescents in the age bracket of 10 to 19 years. In Cambodia, it is as high as 28%. That is not living with HIV, newly acquired HIV infections in the past 12 months. This is based on the modeling estimates, and this is really concerning. And I'm citing these numbers like Myanmar, Thailand, Philippines, Vietnam, Cambodia, but the problem is not only in these countries. Only these countries have enough disaggregated data on adolescents programmatically from the surveys to inform the spectrum and modeling estimates. So this is one point we are working on, is to draw attention to understand the risk and vulnerabilities of youth and adolescents. And we don't really have a lot of population-based surveys for the adolescents. And since it is the household survey, usually it is conducted every 10 years, so the frequency is not optimal enough to understand the evolving risk and emerging risk. And it is the household base, so there is the risk that the adolescent may not be able to speak truthfully according to all these circumstances. So what we are looking at is through the biological and behavioral surveys and serological surveys among the young men who have sex with men, young female sex worker, and young transgender people. And what we have seen is the age of sexual debut, and then the age of engaging in risk is sometimes as early as 10 to 12 years. And this is based on the actual surveys, not just the program data. But on the other hand, it is quite difficult even to recruit adolescents to engage in surveys, let alone access to testing and treatment services. So the age of consent has been a big barrier in terms of accessing prevention and treatment, and other sexual and reproductive health services. And what we have learned through the surveys is also the sexual coercion among the adolescents is quite high among the Yankee population, sometimes as high as 20 to 30% of adolescents has experienced gender-based violence, sexual coercion for the first sex during the sexual debut as well. Another thing is we are trying to bridge the innovations, the digital interface. I could see that Amanda is more technically savvy than me because I'm still holding a piece of paper. But when you look at the adolescents, they can use their phone like within 3 seconds, they can finish so many things, and it would take me maybe 2 minutes to finish that, right? So in that generation, because basically they are the Generation Z and Generation Alpha, they are tech savvy, they prefer authenticity, they prefer inclusivity over all these judgmental approaches and lectures. So we cannot approach them with the conventional and traditional approaches because they are also the visual learners. They want authenticity over everything. They want to learn and see and believe. So we really need to make sure that, so this is we are advocating for is we have to make the services fit for adolescents, not just adolescents, because we cannot make adolescents fit into our services. We have to make our services fit for the adolescents. But at the same time, the word adolescents-friendly health services, youth-friendly health services, has been like lingering around for decades, but it is not yet systematically integrated. It is more like boutique services or the best practice. So this is the time we really need to get serious about making it as a norm rather than some project demonstrations. Yes, we need to learn from that successful example like Birdie Clinic, but we need to replicate and integrate into the health systems to make sure that this is not just the jargon words or the tokenistic approach, but it is the need to access the services. So I will stop here for now.
It's fantastic. Thank you so much. Our next panelist is, Dr. Supunnee Jirajariyavej, who is from Bangkok Metropolitan Administration. Welcome.
Okay, thank you for introducing. I am Dr. Supunnee Jirajariyavej. I'm specialist in infectious disease and sexologist. At the beginning, I care for the HIV/AIDS patient and the STI, and I found a gap that mostly of the STI patients are in the youth. So I interested in this group, and then I integrate the services to another service in the hospital. And my position is a head of community center in Taksin Hospital, with responsibility for the youth clinic and OSCC clinic. OSCC is a one-stop crisis center. And the other responsibility for the addict and rehabilitation center in the community health center department. So I integrate the care of package for the adolescents, include the STI screening, and as you know that mostly problem of the youth, including the unsafe sex or like the chem sex like that, or mental health like that. So I have the team in the community health center department to take care, and the other I collaboration to the Dr. Sansani. Dr. Lee is our pediatrics. She looking for the young adolescents, and the other is the OBGYN doctor, Dr. Noknoy. She's the leader of the OBGYN due to we have the use in the unwanted adolescent pregnancy. That is our policy of the BMA to take care of the teenage pregnancy for prevent the early childbirth. So we integrate all of service, and the other at first we didn't have the STI clinic, but we use the IT catch up the case by catch up the ICD-10. When the doctor made diagnosis of the STI, then it have the pop-up alert that is need to send this case to the receive the VCT and next to the STI clinic. At that time, we didn't have the staff, didn't have the clinic, just only the IT opened the clinic for recruit the case. And the owner is the VCT nurse, because the VCT nurse will usually the STI case has a high risk for screening the HIV, but it's very surprised because the coverage of HIV testing in the STI case in BMA below 20%. But after we use the IT to correct the case and then open the clinic STI, but the owner is a VCT nurse, so we can correct the case, and later we push to the HR. So now we have the 2 nurse manager and has 1 doctor responsible for the STI clinic. And the next is we can stay negative the case. It is the same idea to open the IT to collect the case in the stay negative clinic, because normally you tell the patient to follow up the next month or 3 months, but you didn't know the patient lost or not. But when you use the IT to catch up, so it's very very easy to follow. Yeah, tracking. The last we feedback. We use the data by the feedback the staff that didn't follow the guideline, because when we catch up the ICD-10 like 8 or 11 of the STI, so we connect to the IT and then we print out the report. So we know that staff who didn't screen the HIV or didn't make sent to the stay net clinic or STI clinic. Then after feedback, then now we can catch up the case to stay net and send back to the STI clinic. Yeah. Thank you.
Great, thank you so much, Dr. Supunnee. I thought some really important points you made was about integrated care, using IT to bring alerts, and also having the feedback loop system in your hospital has really helped you to raise your game in managing STIs and HIV in adolescents. So our next speaker, I think, is a hero in many ways in our system. She's a primary care physician and she works for the Ministry of Public Health. Her name is Dr. Sairat Noknoy. Please, can you introduce yourself and tell us a bit about what you do in the adolescent health space?
ค่ะสวัสดีค่ะ My name is Sairat and I am a family physician. My current position there are 2. One is Deputy Director of the Division of AIDS and STIs. And the other is Vice President of the Royal College of Family Physicians of Thailand. So when I received the topic, what I can contribute to the section. So so I think I can tell the story of my development as well to give you a picture when I was in Chonburi Hospital or Chonburi Medical Education Center. In my practice, I do antenatal care. And it's more than 10 years ago. Do you know, I managed to have a teenage pregnancy clinic. So I found that it's a big group, so okay, let's separate them and do some service from a separate service to help them get better care and ensure, because there are a lot of needs, not just the antenatal checklist, but a lot of care, group support, and then I do the assessment. We do the assessment. We expect that they won't have additional birth, and next pregnancy so soon. But then before the service was well received, they are all satisfied, very good result. And then I saw there is a pregnancy afterwards. So we were very disappointed. Also, we are failing, but I'm talking about this just to tell you when we have indicators, we really need to understand the reason of the result. She has a baby because she was very happy and her family was very happy and they are ready to go for the next ones. So just to let you know, because we have lots of indicators, right? Sometimes it might not telling what you are actually measuring. It's telling that it's a good result. So in those days, there are lots of teen pregnancy already in Chonburi, in the city district of Chonburi. Nowadays, what I would like to tell you, our country estimated there are around 8,000 new infections each year. Under this new infection, 3,900 are teen. So you can imagine how much the growth of the clinic, if it still exists, it must be much bigger. And we have the congenital syphilis in Thailand in the past, it was less than 50 per 100,000 births. Today it's almost 200. So the problem is severe. So I think we have been neglecting the promotion and informing people about sexual health. Sexual life has changed a lot. So to tackle this problem at the moment, we are implementing sexual health services in primary care in 4 provinces. I did this actually implementing HIV comprehensive service in primary care since 10 years ago in Bangkok with Warm Community Clinic. We do that with intention to destigmatize, make it like in routine practice, confidential, and normalize its men's health clinic. You come whatever. We promote, in our demand generation, we do like health check-up, and then HIV is part of that. And then the men's health demand generation, do you imagine what was the percentage of positive rate? It was 17%. 17%. And the biggest group was above 50 or older, because it's the stigma. They don't show up anywhere else. And this one catch up, make them feel comfortable, because our promotion campaign is a lot of confidentiality, blah, 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 normalize. And our linkage rate was better than the national rate, because we have care and support from the people living with HIV group or CBOs, and it's like we give name card to the clinic and we tell the patient that call this, or if they allow us with this name card, tell them to call them to have support, to link to the care, because at that time we didn't implement care yet. This time we start implementing with collaboration with CDC, Thai CDC. We now implemented 20 clinics in 4 provinces, and there is a specific model for youth, because in Thailand the system of primary care is reimbursed by the government and under universal health care. And in many universities they have primary care unit with clinicians, with everything. So we are implementing now in 4 primary care clinics, because the population are there, right? And then make it normalized part of the services. What we need to do is a lot about communicating with our team, because everything is very segmented and everything is separated. How to bring them all together, because we have the culture of ownership. This is my job, blah, 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 you can do. So it's a bit complicated. With PSI, under usage fund, we finished and show results of everything completely just in 2 years with all the results and the report ready to publish. But now it's like because of a lot of collaboration, it takes some time to make things in place. But we really hope to collaborate with many and make these scaled up for the nation, including connect with the KP-led or KP group. And I think community-based will be a very important outlet for demand generation and do the care and support. The real work for community is not a lot about providing medical treatment. Let primary care provider, we have more than 10,000 primary care clinics in Thailand.
Thank you. I think your comments really, I think, are a powerful example of how important it is to use primary care to engage in what you mentioned about KP, so key populations, whether it's antenatal care, using appropriate measures to measure your progress. And also demand generation, I thought was an interesting thing that we don't talk so much about, but I think as we're talking about prevention, we can't just always wait for teenagers who have a social life and other things to do. They might not necessarily want to come. And so the other thing you mentioned was about the segmented ownership and how we should proactively try to manage that so that the structure is easier for adolescents to access. Thank you so much. Our last panelist is Professor Thanyawee Puthanakit, so she'll introduce herself. Thank you.
Yeah. So I work at a university, and I would like to address another angles of the service. This morning I talked about the CU Buddy Clinic, which is the integrated care for adolescents, both perinatally and behavior acquired. But I think my point that I work in the university settings, would like to see that in order to have a provide care for adolescent, we need to train more people, either with the family doctors, with the pediatrician to be able to cover up to 24 years old, or have a skill set to communicate with adolescent, or have a multidisciplinary team in order to engage adolescent, or do a programs part of CU of the empowerment of adolescent. I would like to share the programs that we have. It's called, it's like a youth advisory board or a youth group that they come to work with us and guide us, and you can see that they are right at the centers and be able to communicate with their peers in the way that it would be better than us thinking as an I don't want to say elderly, but it's in an older generation way of how to work with them. And I think that one is the one component that in the past, when we 20 years ago, when we start ART programs in the primary care, every hospital, we asked to have we call the people living with HIV to be advocate in the clinic, in the peer. I would like to see some programs that advocate to have youth in, work with hand in hand with, or taking lead in some project or some programs in order to reach out. And the second one is on education. I would like to learn more for other countries in Asia, but I think Thai system is failed in health education. It's more to learn about where is ovary, what is the progesterone, estrogen, and how you have menstruation period means in a science way, but not in a health literacy way of how they're going to use condom, what is the HIV syphilis testing. And I think that one is a big issue. It's outside the Ministry of Health, but we need some integration work to make health literacy work in a practical way, because I think that is a life skill, which is for HIV is a way to prevent lifelong diseases by have programs of education. And we also try to work with different universities to implement sexual health within the university, bring it down to where they live. And I think that is a many things outside the hospital settings that we need to think about if we'd like to tackle on the HIV prevention in adolescents. Thank you.
Can you tell us a bit about the paintings in the room? Can you tell us a bit about what the paintings are in the room?
Yeah, that is the groups of adolescents that they have their own voice. They usually in the past we also have some painting, do a diaries to raise fund or some activities, and also we also have youth groups that come to help us at the booth. Going out we do outreach activities. So I think that's the right person to advise us, and also the manpower to help us in the healthcare system, that it's have to accept that it's only focused on manpower for treatment, but don't have enough manpower for outreach, demand creations, or working as a prevention.
Thank you. So a lot of discussion about the importance of training, about engaging youth service users like the advisory board, education, integration of the provision of life skills for lifelong self-management of sexual health. So we're about 30 minutes into this session now. I want to open this up to the floor now. If anybody has a question, feel free to use the microphone here or just raise your hand and somebody will run you a microphone.
I think it could be questions or
Yes.
sharing from your
your
settings from Philippines,
Sharing,
from
yes.
Myanmar. It's also very welcome for your thoughts or your suggestion in the topic of adolescent care and delivery.
Yes, and I was just speaking to, yes, Melly, please go to the microphone. So we just spoke to some colleagues from the Philippines who, I believe you said you were an HIV service provider and also look after young people with sexual health challenges. Can you tell us a bit more about what it's like in the Philippines and what challenges do you have relative to what's being discussed here?
I'm Dr. Meli Lastimoso. I'm from the Philippines in the southern part. I've been in the STI provider for 30 years actually. I just retired. So the challenges I have is special funding and the sincerity on the program because you work day and night. I work with prostitutes, the male sex with males, and then mother with STIs, and then with mothers who were had a quarrel with husbands. So I had that for 30 years. What are the challenges? The support of the program. So when you want it holistic, well, the services of our government is very ladderized. Well, the budget is only this one, and you work for a little improvement of your program, and that's not a good level for assessment. So when I work with youth, it's so difficult because different behaviors, different interests, and they want it make more improve on their needs. So what I did, I work with them looking for their interest. So I bring the theater in our city. So those who wants to be interested in theaters, they will be teach. One boy said, "Doc, we create a group of singers. I have guitars in our home, but you know they live in the street rather than home. So I will get that guitar of mine." So it's just a difficult one. And then somebody wants a dance troupe, and then they want to go to school. So you have to offer scholarship so that you can get them on the program. So I offered everything I know at my capacity. So they are there. They know me. When they see me, "Doc, how are you?" But at the end of your stay in the government, it ends. Kasi you're not already in the system. So you're in a private. So you don't have more, you have no authoritative to be with them because you have also your needs personally. But now I have children who are HIV positive. I'm into HIV treatment hub facility. So I work every month with them. But the challenge is the medicine is free. They just get it. But you know the problem, they miss pill, they forgot their medicine, they just go back to you when they have illnesses, opportunistic infections. So it's very difficult with these children.
So you're saying there are adherence challenges. It sounds like there are systemic challenges with
Yes.
continuation of care. You mentioned to me earlier that after you retire, there is nobody to hand over this this care
Yes.
to, because you mentioned to me that it's highly stigmatized even in the medical
Yeah.
professional to look after venereal diseases.
I think the challenges also of the program is to equip service provider
Yeah.
to give a full treatment to them that they can accept it, that it gives them feel good, it gives them hope, yung journey from HIV positive at birth up to their adult life. I just always say, just look at Magic Johnson.
Yeah.
Yeah. So but they don't feel it because they don't know who is Magic Johnson at this
Yeah,
young
of
people
course, yes.
anymore.
So it needs to
That's
be like
my time.
relevant to who they know and what's
Yeah.
familiar to them.
We forgot. We always say, take care of them, but no one say, let's take care of the carers.
Yes.
Kasi
Yes.
it changes, behavior changes, time changes, needs changes. So it should be also updated as a caregiver. That's why we're able to go to Bangkok for the first time in my clinic to upgrade ourselves. How to provide more services according to this time at their level of environment. And I'm not equipped much at their level of of generation. I'm backward. I'm 64 years old already.
Looking good.
And I have 2 children, and the youngest sexually transmitted infections is 15 years old. I just want to share the OB-GYN. I referred to the OB-GYN. Doc, what have I to do with the baby, the young pregnant? I don't know. So I just told him, just leave it to me. When they go back, Doc, she's already beautiful after ART treatment. See, most carers, OB-GYN, they just say na refer another patient not with HIV. See, that's that it gives a larger burden to you as advocates of an HIV.
So advocacy.
Yes.
I think you had a comment with what she's saying.
Thank you very much, very, very much.
Thank you.
Because
Thank you.
it's a very important issue, and I was thinking about it this morning too. The development of technology and the growth of of everything, because everything has developed a lot in terms of science. So everything has been growing differentiated, and everyone has been expertise in their tiny world. So they don't know the rest. This is why we have family medicine. And this is why GP, we always advocate. And people see GP, oh, they are stupid, they don't provide good care. Because actually, there is no, because the society doesn't recognize the value. The society doesn't recognize there is no supporting mechanism. My study that Dr. Bawan said, 8.9% go to primary care. There is no investment, then how you can expect good care? So in doing, the system is like growing big hospital, medical hub, blah, 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 everything going bigger, growing their own ego. The world has actually grown in a divide way, because in science we differentiate everything, make it easy to manage and understand and learn. It's good for scientific knowledge development, but it's not good for humanity. It's not good for humanity. And we forgot love of humanity. We forgot connection between each other. In our work as family physician, a lot is about relationship, doctor-patient relationship with specialists, with caregivers, with community and everything, and really need to have broad knowledge. And this is expensive to maintain, but you pay them cheap. You see them as the weakest, non-knowledgeable. So I should better do Botox. Do only one thing. And this is why the system failed. And we need a reform for sure. And if you ask me if I have knowledge on how to do it, I am very confident that I know how to do it. It's changing the world. First is to prioritize love, measures love, maybe consider that. It's hard, but I mean connect more with all. Connect everything. We have all the technology, even AI can do for us. But what we need is connecting, supporting, give our, because I think what I hear from my colleagues, it seems, is specialists is like building their own world and say this drug can only used by me, can buy like the new drug we know the limitations sometimes, but at a certain point there is no need to be limited. Like at time of COVID, I came out and say, you forgot there are clinicians in primary care practice. You don't use them. They can provide support, and we call for volunteer. We got 3,000 volunteers from all the country to support. But what we need is like do the training, but the policy maker doesn't know. I just give some advice, and then they announce the policy right away. They don't know that they need the training. Training, you need to have things ready. So announce urgent and blame that they cannot do it because you didn't. They give a one-day training and expect them to do it.
I think you raised an important point. In your settings or in the policy, how we can leverage on the strong infrastructure of the family doctor or primary care to do more on the HIV front line or integrated in the community, because this morning we also talk about the change in landscape. It cannot be a standalone or one single task, but if it can integrate it to the primary care, what in your settings or with your mind, and also what is your vision as also the society and also the ministry, and then we can, because I really love that idea that it's like nowadays diabetes, hypertension, elderly care is also integrated into primary care, but in the past HIV is stigma and even have a separate clinic. How we can integrate it back, in your opinion?
Thank you for raising this, and actually I have a similar thought on this as well about the family values, because when we have dinner together at the family table, instead of talking to each other, people are looking at our phones. So we are living in more connected, but in a way more connected virtually, but in terms of the bonding, we are less connected. So I'm just like vouching the fact that I fully agree with your comments. So from the policy perspective, I would like to go back to a very simple thing. And primarily, these are the governments. Basically, all the governments in our region, they pledged for holistic healthcare. So holistic healthcare means that not only the treatment, but also the preventive and promotive strategies to ensure the well-being, not only the physical, but also mental and social well-being. So social well-being is also part of the family values and everything. So I think we cannot go back from the digital phase, but particularly for the adolescent, what we would like to ensure is that when we design the policy and services, this is not just the Ministry of Health. This is, like Professor Thanyawee mentioned, that is the multi-sectoral, including the private sectors as well. Because Professor Thanyawee also mentioned that Thailand is failing in the sexuality education. Not only Thailand, I think almost all countries in our region in failing that. Because even the teachers themselves, I heard from the first hand that, oh, I'm shy to talk about how to demonstrate the correct usage of condom and everything. And in their mind, they are still trying to associate that kind of education with a promiscuity or early sexual debut, which is totally wrong, whether they teach them or not. The adolescents and the young people, they are very, they are already going ahead with all these innovation. They are curious to learn and everything. So in terms of going back to that integrated services, I think this is the best time when all the fundings are shrinking. And I've been listening to the Global Fund webinar the other day about the next funding round, next cycle round. They all talking about the integrated services, because we cannot stay silo forever. But that integration needs to be meaningful. That integration needs to be not, because what I'm afraid is adolescents may shy away from the traditional conventional services. But that's why we need to adapt the services, integrate the services in a meaningful way, because mental health, that is very important. They also need to learn about the substance abuse. They also need to learn about the leadership skill, the facilitation, negotiation skill, and there are ways and means to boost their self-esteem. I don't have the silver bullet how to do it, but when we do the integrated services, that needs to be meaningful. That is not to just combine the services, but to make sure that that is combined, but at the same time that is accessible to all the population, including the young people and adolescents. And another thing is that, number one is at the service delivery level, there is the still very high level of judgmental attitudes depending on the age. When the young people are coming in and asking about the sexual education, there is the attitude among some of the service providers as well. So we also need to have a serious sensitization of the healthcare workers. And at the same time, in the society as well, when the young people try to ask about the sexual education, there is a strong social taboo against it. So meaning that it is not just the Ministry of Health, just one government. We have to go as a multi-sectoral approach to make sure that when we integrate, not just for the clinical services, but also for the preventive and promotive services in more meaningful and accessible for the adolescents.
Thank you. That's. I wish we could do that in the United States. I think that's one of the challenges for us. Is I was thinking about where are the gaps in the way that we provide services. And in my experience, I'm seeing patients in a children's hospital. It's not a hospital for adults. It's a children's hospital. It has all of the specialties that the patients need from a pediatric perspective, and yet, we can only do things like give them influenza vaccines, but we can't do their primary care. The primary care is still outsourced to the general pediatrician, and so that becomes a huge limitation in the way that we can provide these integrated services. We obviously are able to communicate with them, but it's not a holistic approach like you were defining. We are lucky enough to have some of the wraparound services, but again, when they go to the adult care, those services don't exist also. So I do think it's interesting also when not necessarily from a treatment perspective, but we certainly have a huge debate in the prevention perspective in the United States, where for PrEP, for example, where we try to get primary care docs or family practice doctors to engage in prevention and HIV prevention. And oftentimes they feel like they don't have the capacity to do that. They don't have the knowledge to do it. They don't have the level of comfort to be able to provide preventive services. And so that's why they send people to us, because they say, well, you have the expertise in that. So I do think that one potential solution to this is to engage our counterparts that are not necessarily as used to working with HIV, whether it's from a preventive standpoint or a care and treatment standpoint, but to give them the tools to be able to work with us collectively to really provide comprehensive services for patients.
Thank you. And I thought both of your comments were very valuable, and I think really highlighted the importance of not working in silos and integrating. So I think we just have a few more minutes left. I wanted a few comments from anybody about what steps if anybody in this room is listening and thinking, okay, so I'm currently working in a very siloed system, which is the case for most people. How do I start integrating? How do I start making it happen? Whether it's from the primary care level, from the hospital level, from the pediatrician level. Any comments or advice?
Actually, we are starting on the 20th, coming 20th. We are seeing together, me and you. This is an example. Let's add the answer first. Just true. We are meeting on 20th. จะทำยังไงให้มัน integrate ได้เพราะตอนนี้มันแยกถ้ามีคนในออเดนที่แบบกำลังจะเริ่มยังไงเริ่มจากที่มันเซอร์วิสแบบ traditional
I think it can beginning with yourself and then success with the team. I think, yeah, because I think the youth can come any clinic, so it just start because sometimes mostly doctors think that the perfection of care like the BMA at the first when the policy to set up the youth clinic, it's too hard. How to screening through like that because in the group below 15 it has a program like that, the screening tool, but above 15 to 24 is so hard. We find out the tool that is proper this group, but the last I think that what is the problem that I found. So I set up only the STI like that, or only the reproductive and the substance, only 3 parts. But the other, like the body, like the mental or something, is the second or is the left. I think it's just start. Yeah, and the second, I think that it's need for the specialist to share the idea that it's not so perfectionist for care, you know, like the HIV now. You turn back to the self-test, like the ATK like that, but in the past it need for the counseling pre and post like that. If you make it easy like the dectal strip, like the DM, like something, or maybe when you start the ARV, it need for the counseling like that, for the ARV medication, but in another like the DM or like the NCD, it's the same, I think. So I think if you look at, is it the same, the basic approach? So it can generalize the adolescent to the other approach, I think.
Thanks, some really good messages. And I think if I had to summarize that in 3 main practical points, number 1, just do it, start, and but prioritize what's important. You don't have to do everything. The second thing is, it doesn't need to be perfect. And the fourth thing is simplify. Don't make it too complicated. Great. Yes, you had something?
Just the example from the Philippines, but it is just only piloted in Metro Manila. Actually, that was funded by the Australian government around the HIV prevention grant. So what they did, actually it's more like a startup project. They have the youth training of trainer, and then they are trained, they call it YHLP, Youth Health Learning Platform. And then their curriculum are age appropriate, but it covers HIV, STI, SRH, substance abuse, mental health, including the leadership facilitation skill. And more interesting part is they do it in the community-based and then peer-based learning approach. And they have the core trainer, a little bit older counterparts of 15 to 24. They started as the facilitator and cascading down to as young as 12 to 14 generation. And then at the same time, they try to engage the guardians and the parents to foster more supportive environment. And another thing that I really like is they are trying to implement this prevention services within the local youth health councils, meaning that linking with the government services. So in a way, it is strengthening the youth engagement, youth leadership, and at the same time, they're trying to promote the community-based prevention, but also, again, linking with the service uptake for those who are testing positive. Again, this is a small pilot project, only limited to Metro Manila, but we need more model like this and replicate in a larger scale from that prevention to service uptake and retention in the services.
And if people in this room want to learn more about the details of this, does UNAIDS publish any of this anywhere? Can you recommend?
Not yet published, but we can make it available later, but we
Great.
can share some more detail as well.
Wonderful. Professor Castel, any other comments on this?
Yeah, I think one thing that has been alluded to during this discussion, and you also, with the example that you brought up in Metro Manila, is that, you know, I think Dr. Thanyawee said we're older, we're not elderly, but that we have to bring the youth along with us, right? We need to talk to them and understand their perspectives. They are way more technically savvy than we are. They have their own minds and their own thoughts about how they want to be approached and how they want their care to be delivered. And I think we need to start by listening to them. Sometimes we can't do everything that they dream of doing, but to embrace their ideas and to integrate their ideas into the way that we deliver the care, I think is really important. Because we can come up with 50 different models, but if they don't work with the youth and they're not centered around the youth and they're not informed by the youth, they may fail. So.
Great, thank you. So definitely focusing on youth-centered, youth-led, and many people have mentioned this services. So I think we just have time for our last panelist before we close. I think you had something to say.
Yeah, I just like to say when mentioning holistic or integrated, it sounds cool. It's always in the top of the policy or patient center. It's always on the vision and everything. Practice is different. It's completely different when in practice. So we really need first to change the system. The system gives us 3 minutes to see patients. This is not a high quality. We were proud. Are you sure? 3 minutes give good care. So first is changing the system to allow patient-centered care. It needs time for good care. And we really need to completely change, and then thinking more about love of others, thinking more about connecting with others. We are too much into succeed, completing the task, and finishing things, and we miss to connect with ourselves, connect with our peers, connect with the patients. If we do that, we will be much more happier and people around us too. And think about changing. Thank you.
Thank you. So, yes.
I have another point. I think that if you would like to start, you maybe see your contact that which part that have the use to service, like in my hospital, the use visit STI clinic, visit OBGYN and substance center. So you can put the value in the task and then give some skill to the each sector. Like now we try to set up the youth clinic, but it failed. So now we separate to the 4 clinic, like the teenage pregnancy, the pediatric, the STI or BK Pride now, and the substance clinic or the clinic. But so you training the skill something to assess the youth that come. Yeah.
Great. So I think the key word here is getting different entry points really to provide similar care in the end. And from Dr. Sairat talked about the importance of the system and the system giving importance to the time needed to deliver this kind of care, and also connecting with the team that's looking after the patients and the patients themselves. So I think we've just run out of time now. So thanks very much for staying until the end. You're probably quite tired now. So we hope you enjoyed this session and hopefully see you all tomorrow. And thank you again to all of our wonderful panelists. Stay for a picture.